Good morning, everyone. My name is Ishaan Immanuel Katumalla, and I'm a third-year medical student studying in CMC Ludhiana, and I'll be presenting on my research project titled A Study of Ocular Profile of Visually Impaired Children in Schools for the Blind in Ludhiana. Childhood blindness is a major contributor to the worldwide burden of blindness. The number of children in India affected by severe visual impairment or blindness is 2 to 3 lakhs, and only a fraction of them have been enrolled in schools for the blind. Majority of the causes of SVI and blindness in children are either preventable or treatable. For this very reason, WHO's initiative Vision 2020, the right to sight, has made prevention of blindness in children its primary objective. Data to collect about childhood blindness is always preferred in blind schools than from population-based studies. The aims of the study was to study the ocular profile of the visual impairment and blindness in blind school children in the city. This was a cross-sectional study that was done in 2 registered schools in the city, namely VRTC and Braille Bhavan. WHO's eye examination record for blind children was used. History, visual acuity, functional vision tests, examinations including anterior and posterior segment evaluation along with IOP was recording as per the protocol. Children requiring further evaluation were further referred to the ophthalmology department in the hospital. Moving on to the results, the mean age was around 12 with a male predominance. Visual loss was present since birth in more than half of the students. A positive family history was seen in 10% of the children. Out of the 100 eyes examined, 65% had no light perception and only 1% had vision more than 6/60. On functional assessment, 1/3 of them could walk independently and only a fraction of them could recognize faces and read print. The most common anatomical site involved was the globe, followed by cornea, uvea, and lens. The most frequent abnormality was phthisis. The other major findings were corneal opacity, cataract, and uval anomalies. So in surgical history, majority of them had no ocular surgery, and among the ones that were operated, there were cataract, glaucoma, enucleation, and other procedures. Congenital anomalies were the leading cause, and other causes included ROP, glaucoma, and cataract. Prognosis was stable in 96% of the patients. So the majority of the enrolled children were male, and it reflects referral and schooling biases that are normally seen in blind school surveys. More than half had blindness since birth, and that emphasizes congenital and early onset disease. Only 10% had a family history suggesting regional or reporting differences. Associated disabilities were rare, and it was 2%, possibly due to the underrepresentation of children with multiple impairments in blind schools. The most affected site was globe, followed by cornea, uvea, and lens. The leading cause was congenital anomalies, and preventable or treatable causes accounted for 1/3 of the entire cases. The previous ocular surgery was low, and it basically indicates gaps in timely access to surgical care. So blind school surveys remain a practical method to study childhood blindness, though there are subjects to biases. Findings emphasize the need for early identification and intervention. This includes neonatal screening and timely pediatric ophthalmic care. The results also underline the importance of strengthening rehabilitative and educational support for these children. So in conclusion, I'd like to say that childhood blindness in the city was predominantly due to congenital anomalies, with globe affecting being the most affected site. Around 1/3 of the cases were preventable, mainly due to ROP, cataract, and glaucoma, highlighting missed opportunities for early care. Very few children benefited from refraction, confirming that most had irreversible pathology. This shows the need for prevention rather than late treatment. Findings are consistent with other Indian blind school surveys, highlighting a national shift from corneal causes to congenital or developmental causes. Periodic blind school surveys can be done every 5 to 10 years, and they can be a practical tool to track these trends. Early screening, timely intervention, and rehabilitative services are essential to reduce this burden. Thank you.
Excellent presentation, and the study was very well conducted because the magnitude of childhood blindness is so high, and it is a huge responsibility on the society. So to make the national programs, or we need to know what is the exact magnitude. Did you include the socio-economic strata of these patients? socio-economic strata of the children who were there in blind school?
No, ma'am, it isn't part of the protocol.
Okay, because there is a majority of patients who belong to the lower socio-economic strata who are not even able to enroll their child in the blind school.
That's true.